Good evening, and thank you for that introduction. It's really my pleasure to be here this evening to talk about colon and rectal cancer. By means of introduction, I've been at Baystate since 2015, and really quite fortunate to be here working with what I consider to be four of the best colleagues that there is. I am board certified in colon and rectal surgery as well as general surgery. And after growing up in upstate New York, I consider myself a transplant Bostonian now, having lived most of my life here in Massachusetts. And this little fella here in the center is truly my being and my reason for really wanting to show him what hard work and diligence pays off. As many of you know, March is Colon Cancer Awareness Month. It's something near and dear to my heart and something that I've committed truly my life to studying and treating. And colon cancer is truly a preventable, treatable, and beatable disease. It's important because according to the American Cancer Society, in both men and women, just behind prostate cancer, lung cancer, colon and rectal cancer is the third leading cause of new cancer diagnosis in both men and women. But potentially more importantly, colon cancer is the second leading cause for cancer's death in the United States. In fact, every 7 seconds, someone in the world turns 45 years old. And I'll speak to the importance of this age in just a moment. Every 3.5 minutes, someone in the world is diagnosed with colon cancer. So at the end of tonight's discussion, that's almost 20 new cancer diagnoses alone. And importantly, every 9 minutes, someone in the world dies from their colon cancer diagnosis. And I think what's particularly stunning from this collection of famous individuals who have passed from their cancer diagnosis is that it's a disease of men and women, young and old, and across really all race and classes. However, the disease is detectable, and even at early stages, many would argue curable, and yet every 5 seconds, someone who should be screened for colon and rectal cancer is not. And this is important because colonoscopy has really been reported to reduce the incidence of colon and rectal cancer by 60 to 90% alone. And I would argue that if these odds were in anyone's favor, we would all take them. And so really, there's no ifs, ands, or buts. If you're of age or have symptoms, you really should schedule your colonoscopy after discussion with your healthcare provider. And so after that introduction, I will spend the remainder of my time discussing the structure and function of the colon. We'll talk about the difference between cancer and polyps and highlight important statistics regarding colon and rectal cancer. I will review risk factors for colon cancer and talk about signs and symptoms as well as screening. And then I'll turn it over to my senior colleague, Dr. Kutayli, who will talk about prognosis and treatment of colon and rectal cancer. The digestive system is quite unique. It's a hollow organ that really leads from the mouth all the way through to the anus. It is important in terms of turning the food that we eat into nutrients and energy. And really the byproduct of that, what exits our body, is fiber. Interestingly, there are over 500 species of bacteria which live in our gut. And this interesting collection of bacteria performs some really specific functions. And the digestive system has its own little mini brain called the enteric nervous system. And it's really controlled by several neurotransmitters, which are similar in the nervous system and have given rise to this idea of feeling your stomach flip in the fight and flight response. As I mentioned, as a small illustration of what happens in the digestive system, if you consider eating a hamburger, the hamburger you eat enters the mouth where it is broken down and digested. It enters next into the esophagus, where I would argue it becomes mini sliders. You'll have to really work with me on this analogy as I'm a vegetarian, but it enters the stomach in smaller pieces yet through the process of digestion as meatballs, and then it enters the small bowel where it further gets broken down, digested, and nutrients extracted before it leaves the small intestine in the liquid state. And the colon is really important in terms of dehydrating, if you will, that into a waste product where it exits the body in the form of stool. And so I like to think of the upper digestive tract really as a specialized waste management system where it recycles and reuses the food into nutrients in our body. If we look specifically at the large intestine, some interesting facts: the large bowel is actually smaller in caliber, is smaller than the small bowel. Large bowel refers to merely the diameter. There's 5 feet of colon versus 16 feet of small intestine. And while many people would like to keep their colon, you can actually live a very healthy and productive life without your colon and rectum. It can take 12 to 48 hours for food that we have eaten to reach the colon. And I alluded to this fact before, that there are over 100 trillion microscopic organisms which live in our colon. If we think about the anatomy, we are really simple people as proctologists. Waste enters and travels up the ascending colon before moving across the transverse colon and subsequently down the descending colon. It swiggles around in the S portion of the colon, which gets its name because of its shape, but also is commonly referred to in diverticular disease, before getting stored in the rectum and exiting through the anus. The colon has a rich vascular supply, which is important in terms of perfusion, but also nutrient extraction. And within this blood supply is the filtration system of the body, referred to lymph nodes. And this is all wrapped in a fatty layer referred to the mesentery. And this is important, especially when we start talking about cancer surgeries and operations. And particularly, patients will often ask us, what stage am I? And really, the final stage requires a surgical intervention to sample the lymph nodes. The colon is really quite unique and important. It's involved in recycling and reusing nutrients. It's involved in absorption of water and electrolytes. The microbiome of the colon aids in homeostasis of our body. It is a reservoir in the rectum, which is highly specific and sensitive to be able to discriminate between solid, liquid, and gas, and is involved in the delicate process of evacuation. It is really the lining of the colon that we refer to as the epithelium, which is shown as this purple layer here, which has both absorptive and secretory functions. And this lining, or the mucosa, gets turned over several times as the cells slough off. It's important in absorption, again, of salt and water, as well as secretion of mucus. And I often refer to it in discussion with my patients as really a sponge, being able to absorb the water to create a formed waste from the liquid that enters the colon. The microbiome over the last 5 to 10 years has received a lot of interest by many researchers. The microbiome is an individual's diverse community of organisms that inhabit the gut. And no two individuals have the same makeup of both good and bad bacteria. And in fact, probiotic is a combination of live good bacteria and yeast that naturally live in the body, with the thought of replenishing and establishing the balance of both good and bad bacteria. And it's important in immune health, anti-inflammatory properties, as well as to create vitamins. And some think that it protects that delicate mucosal layer in the colon against oxidative stress. And so really, if the small intestine is waste management, I like to think of the colon as kind of a very specialized and tricked out, if you will, a dump truck that performs a very complex function. And as I mentioned, while the colon is quite specialized, there are things that can go wrong. And this top layer of the mucosa, which gets sloughed and regenerates several times in one's lifespan, can have abnormal cell growth. And what a polyp essentially is a protuberant above the lumen of the colon. Polyps come in many forms. They can be inflammatory, they can be hyperplastic, but by far the most common is what we refer to as adenomas. And these are important because they are precancerous lesions. They are also the most common polyp, which is identified on colonoscopies. And in fact, most colon cancers arise from adenomas in a very sequenced manner. And this transition from a small polyp to an invasive cancer, or as we move from left to right, in general takes 7 to 10 years, which harkens to the recommendations regarding colonoscopic surveillance. Interestingly, however, most adenomas are asymptomatic until they become larger, in which they can lead to bleeding. When there is one polyp or adenoma, there tends to be more, with a 30 to 40% chance of having additional precancerous polyps. And as I mentioned, 80 to 85% of cancers developed in a somewhat sequenced manner from adenoma to cancer. And in this setting, size matters, as larger polyps have a 40 to 50% chance of harboring abnormal cells and eventually cancers. And as I referenced, it does take time. Growing from 5 millimeters to a centimeter takes approximately 2 to 3 years, and an additional 3 to 5 years to go from 1 centimeter to a cancer. Much research has been done regarding the sequence from adenoma to carcinoma in the early 1900s, and it's shown that it progresses somewhat in a fairly uniform nature, with several mutations in very specific genes, which will be important when we talk about screening modalities in the future. And colonoscopy is important because it's really one of the best ways to remove precancerous polyps before they have the chance to become an invasive modality. And this here shows a polyp, this abnormal tissue, which is being removed during colonoscopy. And as I mentioned, colonoscopic surveillance was associated with a nearly 80 to 90% reduction in the rate of cancer incidences compared to those who did not undergo colonoscopy, which I think really highlights the importance of colonoscopies. Several people will ask when they come to our office, well, what are some risk factors for colon cancer? And we think of risk factors as both modifiable and non-modifiable, meaning we have the ability to impact change and risk reduction methods. And I would say that there's probably no one specific cause for colon cancer, but several, multifactorial reasons. But just like other cancers, cigarette smoking, excess body weight, and obesity, as well as diets which are high in red meats or processed meats, and consequently low in fruits and vegetable, which is fiber, have been shown to have an increased risk of leading to polyps and cancers, as well as inactivity, in which many suggest may be due to the increase in the people who are under 50. In terms of non-modifiable risk factors, a history of colon cancer or polyps is certainly very important. So it's important to have these discussions among family members. Not many people like to talk about their colon or polyps, but it can be helpful when we're trying to assess risk. Hereditary cancer syndromes, while not the common form of cancer development, do account for about 15% of cancers, along with inflammatory bowel disease and a history of childhood malignancies in which there was radiation exposure. We also know that as people age, there's an increased risk of polyps and cancer formations. And while cancer does not discriminate based on gender, we know that there is a higher propensity of colon polyps and cancer in men, as well as in African American compared to Caucasian races. Also, certain comorbidities, including diabetes, cystic fibrosis, and transplantation, have been found to be higher in people with a risk of colon cancer. And so the question becomes, well, can we prevent then colon polyps and therefore prevent cancer progression? And I would argue that a healthy diet high in fruits and vegetables, as well as fiber-rich foods, would be important. Maintaining a healthy weight, as well as limiting red meats. And there have been some studies that have looked specifically at chemoprevention, and popular compounds are calcium and vitamin D, aspirin, and particularly COX-2 inhibitors. And the reason for this, if we reflect back on the adenoma to carcinoma sequence, you can see that aspirin and other NSAIDs, as well as folate and calcium, can kind of block this transition from normal epithelium to abnormal kind of cell growth at several steps. However, in longitudinal studies, the role of chemoprevention has not shown durability. And in fact, in reference to COX-2 inhibitors, while they have been shown to reduce polyp formation by 30 to 60%, there have been several risk of cardiopulmonary compromise, and therefore they have fallen out of favor for colon polyp prevention. In 2017, there was a sentinel paper out of the National Cancer Institute that looked at the incidence and patterns of colon and rectal cancer over a 25-year span. And interestingly, while colon cancer rates had been decreasing uniformly across the United States, there was a curious increase among colon and rectal cancers, particularly in young adults, those less than 50. And in fact, it showed that this incident rate had increased on the average of 1 to nearly 3.5%. And more specifically, if we look at this in graphic representation, where this represents 20 to 29-year-olds, 30 to 39-year-olds, 40 to 49-year-olds, and 50 to 54-year-olds, we've seen that there's been a steady increase in colon cancers among particularly 20 to 40-year-olds in comparison to adults who are 50 and older. And I suspect that this represents the impact of colonoscopy screening above 50. And this same trend has held true when we consider rectal cancer, which has increased at a more staggering trend with up to nearly a 3% incident increase in young adults compared to older adults. And it was really based on this study that in 2018, the American Cancer Society had recommended colonoscopic screening for adults who are aged 45 and were considered average risk. And therefore, the cancer screening guidelines have been pushed to age 45. And interestingly, many of my patients, when I recommend or talk about cancer screening in 45-year-olds, always wonder about insurance coverage. And I received this document from Health New England not too long ago about services that were covered in benefits. And we look here at colon cancer screening, and Health New England is covering screening for members starting at 45. So we're really, moving the cancer screening age to much sooner. And so then what clinical presentation should we be worried about? A lot of times patients will tell us, I had rectal bleeding, it's just my hemorrhoids. And the hemorrhoids always receive, a bad rap, if you will. But there are three kind of typical presentations for cancer: those in which there are suspicious symptoms and or signs. That can include blood in your stool. That can include change in bowel habits, both consistency and the shape of our bowel movements. It can include unexplained weight loss and weakness and fatigue. There's asymptomatic people who have otherwise felt fine, have not noted any change in bowel habits, but were undergoing colonoscopic evaluation when they were discovered to have a colon cancer. And then more recently, in the age of COVID, we've seen a slight uptick in emergency admissions and people presenting with bowel obstructions, overwhelming abdominal infection, and significant bleeding. Importantly, early stage cancers are commonly, as I mentioned, asymptomatic. And really the goal of colonoscopy, if not to prevent colon polyp progression, is to detect early stage cancers which have better prognosis. But unfortunately, most cancers are usually diagnosed after the onset of symptoms and have been related to higher stage or later stage of presentation. As I mentioned, symptoms from local tumor can include change in bowel habits and rectal bleeding. There are a few patients who have persistent abdominal pain who will present with findings consistent with colon cancer. And iron deficiency anemia, particularly in our older population, should always be worked up with evaluation by upper and lower endoscopy. But of all these symptoms that we've talked about, the diagnostic odds ratio, or how accurate they are in terms of diagnosing a colon or rectal cancer, is actually quite low, but best for rectal bleeding and weight loss, but with relatively poor correlation. And finally, there are patients who can present with metastatic disease, and metastatic disease means cancer that has spread outside of the colon. This happens in about 20% of patients who present with abdominal distension or bloating or right upper quadrant pain, which can hearken to symptoms of liver involvement. And very rarely have we seen local invasion of either the bladder, the uterus, or prostate when it comes to colon and rectal cancer. But presentation has an impact on prognosis, which we are all concerned with, and it is important with all of our patients. And we know that patients who typically have symptoms at the time of diagnosis typically present with later stage cancers as compared to those who were found with asymptomatic screening. It's also shown to have prognosis with higher death rates, recurrent rates, and shorter disease-free survival when patients present with symptoms. So really paying attention and listening to our bodies is quite important. And I think the biggest thing to hopefully take away is, how do we assess risk? When does a patient need to be referred for ongoing evaluation or to undergo colonoscopies, which have such a significant impact on cancer development? As I mentioned, risk can be stratified as those with average risk and higher risk. Average risk individuals have no personal or family history of colon cancers or polyps, and we typically consider patients 45 years is when we would start screening. Some of my older patients or octogenarians always ask about, well, when do we stop screening? And what my general answer is if you were to find something on colonoscopy, if you're well enough to undergo treatment, then we should continue to screen to diminish the risk. And then finally, there's high risk categories based on personal history. This is where a family and personal history is quite important. And this includes a history of first degree relative with colon cancer, a personal history of colon cancer or polyps, as well as a history of inflammatory bowel disease. And that would certainly change our recommendations for when a person should start colonoscopic screening, meaning we would typically screen earlier and at an increased frequency. In a talk in today's day and age would be remiss if we didn't take a moment to recognize truly the impact of COVID-19 really on all facets of life, but also on cancer screening in the United States. And as any people know, we often ignored symptoms. We didn't follow up with screening. The healthcare system had really shut down. And this is an interesting study that looked at cancer screening for breast, colon, and cervical cancer from 2017 to 2020. And you can see that cancer screening had been fairly stable for many years, but in March of 2020, really cancer screenings came to a halt, with very few colonoscopies being done. And the impact of this is thought to be a 1 to 3% increase in excess breast and colon cancer deaths per year, for the next 10 years. But what also has been interested when we consider the impact of COVID-19 on colon and rectal cancer is that while colonoscopies really suddenly declined in March of 2020, other screening modalities like the FITC test, which is a fecal fecal test to look for blood, and what's commonly referred to as the Cologuard became much more prevalent as an adjunct to colonoscopic screening during this time. And so screening is really the process of looking for cancer in patients without symptoms. Again, this is important because we know that without symptoms, it's typically, if detected at earlier stage, and a better prognosis. And there are two basic ways to do this. One is with stool-based tests, which are less invasive, they're easier done, and typically don't require a bowel prep. And the second way, which is more common, is the colonoscopy, which is really a visual and structural exam. If we think about stool testing, the most common is something called the FITC test. This is where you're looking for hidden human blood in stool that can be performed at the primary care's office. It is not affected by food and medication, and typically is repeated yearly, and it's fairly inexpensive, on average $8, and its sensitivity or ability to detect cancers is about 55 to 100%. The other stool-based test that is commonly performed is what's called the Fecal Occult blood test. It's, not quite as sensitive as what's referred to as the FITC test. It's once again looking for blood in stool, but is not specific to human blood. There are several dietary and medication alterations, and this generally requires 3 samples to be collected over time and should really be repeated yearly. What has become more common today is referred to the Cologuard. This is actually a combined test looking for abnormal DNA in your stool. This harkens back to the adenoma carcinoma sequence when there are specific genetic mutations that can occur. And this test looks specifically for a mutation in KRAS, and they combine this with identifying blood in the stool. It is covered usually by Medicare and Medicaid, on average costs $650. It is FDA approved, and it's more accurate than any of the other stool-based studies. There are no dietary modifications. It can be performed in the comfort of your home, and typically is done every 3 years. And this looks at how good is Cologuard or any of the stool-based tests at detecting cancers. And it's fairly good. It detects 92 to 94% of cancers, but potentially less helpful in detecting precancerous lesions and high-grade dysplasia. And I would offer that if we're going to be doing a screening test, I would prefer to detect early lesions or precancerous polyps, so that we never have to deal with a diagnosis of colon and rectal cancer. With the Cologuard, there are several people that really should not use these adjuncts to colonoscopies, people with inflammatory bowel disease, personal history, worrisome symptoms, because these are all high-risk features that really require a colonoscopy. And so visual exams include colonoscopy. It does involve a bowel prep, and I'll talk about that in a moment. Here at Baystate, we do that with the comfort of anesthesia. It is both diagnostic and therapeutic, meaning if you have symptoms, we're able to evaluate a luminal cause for those symptoms. And if there are polyps, we can certainly remove those, and therefore it's therapeutic. It's very good. It's very good at finding and treating cancers and adenomas if they're present, and the complications are quite rare. In fact, the complication rate is reported as less than 1 in 1,000. It is covered by all insurances, and depending on a patient's risk, is generally repeated every 10 years. I would say very rarely or infrequently have we used a CT colonography. This is using radiology and CT scans to take a look at the colon. A bowel prep is still required, and air is needed to be insufflated in the colon in order to evaluate for small polyps. It's associated with radiation exposure. And while its sensitivity and specificity is approximately 75 to 100%, it does have the possibility of missing small lesions. And certainly if it's positive, patients are generally recommended to undergo colonoscopy. This is an interesting graph that kind of compares really all of these modalities, including colonoscopy, FIT-C, and the Cologuard test on the far right. And what this shows, if we look at the purple boxes, is that these tests are usually very good at detecting cancers, but of all these modalities, colonoscopy is the best at detecting precancerous lesions. And I think that's important, if we're ever going to really get to a point where colon cancer is truly preventable. And so many people are like, I don't want to do the prep. I'm not drinking all that liquid. And this is kind of what they think of when they think of colonoscopy. But I would argue that this is what I think of when I think of colonoscopy. It's generally Gatorade, Miralax, and a gentle laxative. The volume is much less. It's very palatable. It doesn't have a bad taste. And it's generally done in the comfort of your own home. And so really gone are those days of drinking the 4 liters of fluid. There are many myths regarding colonoscopies. We've heard them all probably in our office. We've heard my colonoscopy can wait, but really cancer doesn't take a break. I don't need one if I don't have symptoms. The idea is to really treat early stage cancers, which rarely have symptoms. People have said the prep is horrible. And while I would say previously that may have been true, gone are the days of consuming a gallon of poor tasting liquid. A colonoscopy is painful. And I would argue that you really should not experience any pain. And with the aid of our anesthesia colleagues, most patients actually tell me it was one of the best sleeps that they've had in a long time. We've heard people say, I don't have any risk for colon cancer. But really, if you have a colon, there's always risk. I haven't heard this one as frequently, but I'm a woman and less likely to get colon cancer. And while that is generally true, gender does not impact our screening recommendations. Colonoscopies are expensive, or I can't take time off of work. And I would argue that most insurance plans cover colonoscopies. I've covered this already. Colonoscopies are dangerous. One of my, People have said, oh, one of my friends had a complications, but actually the risk of perforation or complication is extraordinarily low. Some people, it's not a topic that everyone likes to talk about when we're talking about colon health. They say it's embarrassing, but really every effort is made to make it comfortable and respectful. And finally, colon cancer can't be prevented, but I would argue that finding and removing colon polyps is the best way to really prevent colon cancer. And so in honor of National Colon Cancer Awareness Month, I would argue everyone should take the leap, jump in, really schedule your colonoscopies. There are many ways to cover your butt, but a colonoscopy is by far the best. And if by chance you get a diagnosis of colon cancer, I'd argue take a deep breath. As this quote says, no matter how hard things seem right now, you can and will get through this. And you'll get through it really with the aid of the colorectal surgery department. And these are the four of us. And I would like to thank you for your time. And I'll turn it over now to my colleague, Dr. Kutayli.
Thank you, everybody. Again, I really appreciate your time this evening. I know it's, everybody would like to probably be home and having dinner and all that, but so I really do appreciate that you're, taking this as an important opportunity. Where Dr. Sheldon left off, I'd like to pick up to basically say that, okay, so you've been diagnosed with colon cancer, you've gone through the screening. What does that mean? What happens next? Those kind of things. I will just say that for disclosure, hopefully you'll just be educated and entertained. We're colorectal surgeons. We can't help but indulge in a little bit of potty talk. But on the other hand, even though I'm the director of robotic surgery at Baystate, I have no financial conflicts of interest. I have no reason to recommend one thing over the other from that perspective. So everything that you hear about hopefully is basically my either opinions or and I'll mention those when they are, and basically what the literature says. So when people come to our office, and the first thing they have, the first question a lot of people is, okay, well, what stage am I? So we'll talk a little bit about what the staging is, what staging means, how that affects your treatment, things like that. Obviously, when people are coming to a surgeon, the next question is, well, do I need surgery? I'm here to see you. You're the surgeon. So, and there's this, not fear, but like there's this expectation that, like, the old adage, don't go to the barber and ask him if you need a haircut. It's, but honestly, as surgeons, and hopefully you'll see, is that we are part of a larger team, and we are, making decisions in conjunction with the patient to offer the best long-term care. Another common question is, will I have a bag, like an ostomy, colostomy, ileostomy? And again, what we'll see is that kind of depends on, where the cancer is, what the specific factors are for the patient, and what kind of life can I expect to have now that I have this diagnosis of cancer. What does that mean, et cetera? And also, what does that mean for my family? What do I tell my family about this? How does that affect screening for them? So the most important thing to realize is that, just as I said a second ago, it is not a single person. It is really a whole cast of characters. And that includes, the primary care physician who is doing your wellness check and gets your yearly labs and finds the, iron deficiency anemia that Dr. Sheldon had mentioned, who then refers you to your GI doctor who does the colonoscopy. It, also depends on the pathologist who reads the pathology from the polyp or the tumor that's found, and referred to us as the surgeons. We work alongside with the medical oncologists who are responsible for, if you need it, the chemotherapy. Radiation oncology, sometimes in rectal cancer, might be required. As we go through staging, we need to have our radiology colleagues read all the films that you get. If you need a bag, we have intrastomal therapy nurses who do education and marking. But also we have, social workers, counseling, genetic testing, genetic counseling. It's a very robust, multidisciplinary approach towards cancer. Gone are the days, as Dr. Sheldon was saying, of, you have a diagnosis and there's a predetermined path. No patient is a number. Every patient's an individual with their own series of circumstances and pathologies. So what do we do? George Foreman used to, or probably still says, he had an adage that you plan your work, then you work your plan. And effectively, when you get a diagnosis of cancer, you need to go on a fact-finding mission. We need to find out, well, what kind of cancer is it, where is it, what other factors in staging will come to bear. And then we form a plan based on that with the multidisciplinary team, and then we go through the work of doing that. And as new information comes to light, we shift our plans. So how does staging occur? What does staging actually mean? One thing I always tell patients is that it's the first question that most people have. Oh, I have cancer. What stage am I? And ultimately, what I think is most people are just hoping not to hear stage 4. Because from movies, TV, etc., we've come to learn that stage 1 means it's early, stage 4 means it's spread everywhere, and obviously you'd rather have early cancer than spread everywhere. What I will say is, just as we've seen with breast cancer, the staging for colorectal cancer and most other cancers is likely to change over time. What it doesn't speak to is what the biology of the tumor is doing. So what you'll see as we go through the staging paradigm here is that it's discussing where the tumor is and the cancer. Where is the cancer? Has it spread, et cetera? But it's not mentioning anything about the actual cancer biology itself and how that will act. And we will take that into consideration as well. But essentially, the Tnm staging system consists of T for tumor. We're looking at the size of the cancer. As Dr. Sheldon had explained, that basically these are polyps, which are the inner lining of the colon, and they can develop into a cancer. So from the inner lining, how far into the colon wall has the tumor invaded? And that is referred to as the depth of invasion. Has it exceeded the limits of the colon, and now it's invading other organs outside of the colon into adjacent organs? The N is for nodes, lymph nodes. So the lymph nodes we kind of think of as this almost like a sieve, or the first line of defense for as cells are trying to escape into the system. They will oftentimes go to the lymph nodes, and the lymph nodes will trap them. So if we see cancer cells in lymph nodes, that gives us a sense that the cancer was trying to spread elsewhere. And that kind of gives us a different view of staging, which I'll go through here in a second. And then M for metastasis. Has the cancer spread to any other organs? The most common place for colorectal cancer to spread is the liver and the lungs. And that, as you will see from this slide, will dictate the planning of our work and what we need to order for patients. So basically, when we look at the Tnm staging system, stage 1, 2, 3, and 4, again, what I tell patients is this doesn't relate to biology. So as I always explain, like if the two of us had a stage 4 colon cancer, but your cancer is extremely treatable with chemotherapy, et cetera, and mine is very resistant, overall, the person who has good responses is going to do better. So basically, stage 1 is referring to these tumors that we define as T1 or T2, meaning it's not really very far into the wall of the colon. Stage 2 will refer to cancers that are slightly bigger, that are not quite through the colon, but they're trying. And then stage 3 is basically any cancer where we've seen lymph nodes. So no matter how small the cancer, if it's in the lymph nodes, it becomes stage 3. And stage 4 is for metastasis. If it's gone anywhere outside of that organ and into the other organs like the liver or the lungs, that is now considered stage 4. So planning the work, what does that mean for us? So generally stage 1, if it's localized and it's just in the organ, that's when we go ahead and do surgery right up front, because we're just going to take that organ out along with the lymph nodes that go along next to it and assess, is this indeed stage 1? Stage 2, depending on the size of the tumor and some of the other characteristics, again, referring to the biology, looking at it under the microscope, that may or may not entail chemotherapy. And the idea here is that, and again, not to be too simplistic about it, but if the cells are telling us that they were trying to escape into the system, that's where you might think about like flushing the system with chemotherapy to try and get a hold of things, try and get those stragglers before they get to set up shop and take root in the liver and the lungs. Stage 4 is kind of a unique thing in that, and we'll talk about that here in a little bit. If it's spread to other organs, what we know about colorectal cancer is that what will decide the prognosis in terms of longevity is really the systemic disease. And so we need to kind of start thinking about, we're treating cancer, we're not treating the colon per se. Like the colon may have been the origin of this, but what's really going to affect the overall survival is going to be the systemic disease. So again, with staging, we're still fact finding. So what does that entail? Well, we would want to get imaging. So CT scans, in some instances, MRI for rectal cancers, maybe rectal ultrasounds, PET scans. When we want to look at the liver and the lungs, that's why we get those CT scans to see, do we see any evidence that it has spread elsewhere? CTs are not that great at looking at lymph nodes necessarily, or even to tell us how big the tumors are, but they are much better at looking at those other kind of soft tissue organs. MRI is used when we're looking at rectal cancer because it gives us a much better definition of the muscular wall of the rectum and how that relates to the other pelvic structures, as well as ultrasound. PET scan is used as an adjunct. It is not a first-line exam. One of the questions that we always get is, well, why don't we just get a PET scan every year? It's not a screening tool. A PET scan is not really, it's been kind of mislabeled as the cancer scan, and that's not necessarily true. It's just looking for highly active cells, of which cancer cells can also be highly active. But sometimes you have very slow growing cancers. Sometimes if you have an infection, you're going to see active cells in that area as your body's trying to fight off that infection. So it's not necessarily very specific if you're just going fishing. But if you know that somebody has a cancer, you can use it to kind of compare different regions to see, has that cancer spread, and is the same activity where I know the cancer is, does it look the same in other areas of the body? Other things we would order are also labs, and that includes these markers, these proteins that tumors make. One of these proteins that colon cancer can make is called CEA. And we monitor that because if we see that it's high initially and we do our treatments and it comes down, then we know that we have response, and then we can monitor that as a lab going forward. So if we see that starting to rise, we'll start looking again and saying, okay, we need to start looking more closely to see if this is coming back. Also, genetic testing for a variety of reasons, whether there are other factors in terms of age, other comorbidities, family history, any characteristics of the actual biology of the tumor itself. Every colon cancer gets looked at for certain genetic markers to just see, does this look like this might be a genetically induced cancer, or is this just a bad luck cancer, just grew out of a polyp? So going into this survival data here, these are kind of busy slides, so I just want to break it down and leave you with a follow-up to what Dr. Sheldon was saying, which is to say, as time has gone on and we've gotten better at screening and better at detecting polyps before they turn into cancers, we're finding a lot of cancers at lower stages, and we're being able to treat them more effectively, or even in a lot of cases prevent a cancer from happening. And therefore, we're seeing the survivals going up. And so you can see here the 5-year relative survival and percent of cases by stage. It's predominated. What predominates here are the earlier stage cancers, and the survival in earlier cancers, you can see as on this bottom slide here, is much, much higher. We have over 90% for stage 1, and stage 2 and 3 is 72+%. And these obviously will change as our modalities for treatment change. This is another representation, and again, when we're looking at this, we want to see that the rate of new cases of cancer is actually on the downturn here. And that's because, again, like we were talking about, we're doing a lot more screening, colonoscopies. People are starting to embrace that a lot more. It's becoming more of a routine thing. And we're looking at the death rate. The death from colon cancers is also going down. And these are good things. Down below, we see the 5-year relative survival, and we're seeing that survival is actually going up as a matter of finding cancers earlier, treating them more effectively, really tailoring effective therapies for patients. So once again, just what do we take away from all this talk about stage? is that ultimately biology is king. We really need to know what kind of cell type it is, what are some of the genetic markers in there, how will it react to certain therapies. What we're looking at is to try to prolong life as well as quality of life. And one of my attendings, one of my mentors used to say that you have to love your patient more than you hate cancer, because oftentimes you can put a patient through a lot. And just because you can do it doesn't mean you should, especially if the patient, you need to listen to the patient. And if they're telling you, this is what I want for myself, and this is how I want to live the rest of my life, and this is how I want to die with dignity, etc., you have to respect that. Even if there is more that you can do, you need to be able to have those discussions. And once again, thinking about that we're fighting the cancer and not the tumor. And that's important. It sounds kind of silly to say it that way, but in reality, we want to fight the cancer wherever it is, and not just the actual tumor itself, as like, because a lot of patients will say, but the cancer is still in my colon. Why am I going through chemotherapy or radiation? Just take my colon out. And again, we know that survival has a lot more to do with what it's doing to the whole body than it does to just the organ. So you've come to the surgeon, and now you want to know, well, what's the role? I'm seeing you. Why am I here? Why am I talking to you as a surgeon? And as a surgeon, we have to determine, one of the things we want to know is this a colon cancer or a rectal cancer? And I'm going to show you a slide here to, Dr. Sheldon went through a little bit of this, but to differentiate, why is that important? Why is there really a difference with that? Another question is, well, how much of this will you take out, and will I miss it? And it pains me to say that the organ of our specialty is dispensable. It's nice if you have one, but if it's making you sick, your colon can go, and people will adapt. The body's very adaptable. The main job of the colon is to reabsorb water. It doesn't really do much at all for our nutrition. So you can take the colon out, and what you then have to just watch for is things like dehydration, having looser stools, etc. But we have ways to sort that out, and the body does adapt over time. So once again, just looking at the anatomy here, we see that the colon, this is the patient's right side. The appendix actually grows out of the colon, and so oftentimes when we're taking part of the right side of the colon out, I often have to mention to patients that if you still have your appendix, we are taking that with you with this with the colon specimen, so you'll never have to worry about appendicitis. As you can see here, the important thing to realize is that the lymph nodes follow where the main arteries are going. So, and you can see here how there's a lot of red here, a lot of good blood supply here, not so much on this side, and then a lot more blood supply here. That helps us determine. So, patients will say, well, if my cancer is, say, here in the right side of the colon, why are you saying you need to take half of my colon out? Why not just take this part out? That has a lot to do with the blood supply, but also with the lymph nodes and how they're tracking. So we want to get all those lymph nodes to make sure that we're not leaving any lymph nodes behind, and getting an appropriate staging for that. And similarly with each part of the colon, that's a discussion that we would have. The rectum is in the pelvis, and it's anatomically different than the colon. And it's also fixed, whereas the colon can flop about. The rectum is pretty fixed in the pelvis, which is why it might make a good target for radiation, whereas you can't really radiate a moving target, such as the colon or the small bowel. So again, moving on to the other question of, well, will I need a bag? Not all bags are created alike. There's multiple types of ostomies. The two main ways to think about them are an ileostomy or a colostomy. You might tend to hear these terms interchangeable just in day-to-day conversation, but there really is a difference. An ileostomy is a bag where the small intestine is letting the waste out, whereas the colostomy is where the colon is letting the waste out into the bag. And as we just said, the colon reabsorbs most of the water from the stool, which is why our stools are solid. So you can imagine that the output in that bag will be a little bit more paste-like and liquidy with an ileostomy, versus where a colostomy, it'll be a little bit more like stool. Then we have things like how we create them, an end colostomy versus a loop colostomy. More importantly, a lot of patients really kind of want to know, is my ostomy going to be temporary, or is it going to be permanent? What I say to patients is that, first of all, it depends on the cancer, your personal situation, etc. because even though we may have the anatomy to put you back together, it may not be in your best interest. And I think of a number of my patients, especially elderly patients, who had baseline incontinence to stool and were actually trapped in their homes because they just couldn't leave. They were wearing diapers and it was embarrassing and it smelled, and they just didn't have an active social life. And then we give them an ostomy, and now they're, the ostomy doesn't smell. It's not like our parents or grandparents' ostomies. The adhesives are better, the filters are better, and these patients are actually now living a much more full life. And I've actually offered reversal for some patients, and they say, "No way, hands off my ostomy. I'm actually living a better life now than I did before." So, no, and that's fine. There's nothing wrong with that. And again, what we need to really think about is quality of life. What are the things that are important to you as the patient, and how can we help you achieve those goals? So then we get into the actual things about surgery. So I need the surgery. What does that mean? So, how big will my incision be? Will I need, will I need to have a big incision like the quote unquote zipper incision, or can I have more of a minimally invasive or keyhole surgery approach? The four of us at Baystate, and I think most board certified colorectal surgeons, such as ourselves, are doing minimally invasive approaches, which is to say, laparoscopy, robot assisted surgery, which is also a form of laparoscopy, but also transanal surgery and endoscopic surgery, which is doing certain procedures through the colonoscope. And some of our GI doctors are trained to do some of these advanced procedures. And so we, again, in this multidisciplinary approach, have a discussion about which way, what can we offer that will be the least traumatic to the patient's body, giving the patient the best long-term outcome and quality of life. So, people then ask, well, what does robotic surgery mean? And, I had one patient say, and, does that mean R2D2 is operating on me and you're out there having a cup of coffee? And no, the answer is no. I am a self-avowed, very proud nerd and geek. I disagree with my wife that I'm a dork because that's a very different entity, but we'll talk about that if we need to. But basically, Davinci robotic surgery, the Davinci robot is the kind of standard robot that's out there right now. There are other companies that are currently, making prototypes and trying to create their own robots. But right now in the market, pretty much when you talk about a surgical robot, you're talking about the Davinci robot. And what you can see here is that the surgeons are sitting at these consoles and using instruments and foot pedals. And the robot is docked at the patient with the patient here, and we have assistants at the bedside. The reason that we have our heads in this console here is that what we were actually seeing is a 3D view. So it's basically almost like doing open surgery, except through small incisions. And because the camera has two lenses on it, and so you really are seeing a depth of field. The instruments have 7 degrees of rotation and angulation, so that you can really have very fine movements, pick up tissues, and the magnification is 10 times. So it's actually even higher definition and higher magnification than what we get with regular laparoscopy. So what does that look like? And I apologize, there are going to be a couple of slides here for those who kind of are a little sensitive to things like anatomy and things like that. But the next slide is basically, here's a patient where a robotic surgery was performed. These are the keyhole surgeries. This was the extraction site. Sometimes it can be around the belly button. And this was the entirety of the colon was removed through those small incisions. I often warn patients that not to let the little incisions fool you. You had the same big surgery on the inside. And so a lot of times, people will start getting too hard on themselves, like, well, I'm feeling really kind of fatigued. Well, yeah, your body's using the energy, directing it inwards towards healing, despite these small incisions. So everybody, well, not everybody, a lot of people kind of during these talks will clamor for video. Well, what does that really look like? So I'm just going to warn you right up front that I'm going to show a few, just maybe a minute, up to a minute of some of this video here. It is of a robotic surgery doing a resection in the pelvis. It's really not bloody, which is, again, one of the beautiful beauty and the benefit of a robotic approach is that the tissue planes are so well. So just as a warning right now, if you want to kind of look away, I can tell you again when to start looking. And so this is for an abdominal perineal resection. We are looking down into the pelvis of a female. This is the uterus. The patient's head is out of the screen towards us. This is the sigmoid colon that we talked about going down to the rectum. And here we're seeing the planes, and we're opening up, and you can see we can move the camera, and we have these instruments, and we can actually see these planes quite beautifully. We can see structures like the ureter, which delivers the urine from the kidneys back behind here to the bladder, which is all the way up front here by where the uterus is. This is the main vessel that we were talking about. So all the lymph nodes are running in this tissue here, right alongside this. So that's why we're able to really find it all the way down to the root of that vessel, and where we can isolate it and then transect it with the use of either energy devices or surgical staplers. So for instance, here we're using this energy device that burns on both sides, and then there's a knife which will come down through a tract and cut down the middle. And so then we can even mobilize further, going down into the pelvis. And you can see the visualization is really good for us as surgeons. We're able to really use these wristed instruments to our advantage with very minimal blood loss. So for those of you who are looking away, you can look back, video's over. Other ways of approaching things is with transanal surgery. So if there's a large polyp or a very early cancer that's in the rectum that we can actually see or get to, we have special instruments that we can use, where we use essentially these laparoscopic-like instruments to do what we need to do through a smaller incision. So moving on to what does the future of medicine in general, but surgery hold for us? Again, as I just said, I'm a self-professed nerd. This is a scene from Star Trek IV, which we can argue about whether it was a good movie or not, but this is just to set the scene here. They've traveled back in time to rescue, and now they're to rescue the Earth. They have to get whales or something. But now Chekhov is in a hospital, and this is Dr. Bones McCoy wandering through the hospital looking for Chekhov.
Oh,
What's the matter with you?
kidney dialysis.
Dialysis?
My God, what is this, the Dark Ages?
Here. You swallow that. And if you have any problems, just call me.
So what we don't see the scene after this a little bit later is as they're walking out of the hospital, this patient here is now practically jumping for joy, saying, I grew a kidney, and the doctors are all whispering in the background, it was a miracle, it's great. And, what was science fiction will become hopefully science fact one day, as we are developing, very directed therapies towards cancers and maybe even preventing cancers and things like that. As far as surgery goes, this is one of the newer technologies that's out that we do not have at Baystate just yet. I'm working on that. But essentially, this is a Davinci robotic instrument. That whole opening you see there is just over 2 inches. And so you can imagine the applications where we can do transanal surgery, or we can do even abdominal surgery in the future. This technology just came out on the market and got approved. But basically, using very small incision, you will be able to have all of the articulation that we saw earlier in that video through a much smaller incision. And that is to our benefit and our patients' benefit in terms of recovery time, less pain. I will tell you that a lot of our patients who are having robotic surgery are not needing narcotic medications afterwards, or if they do, it's very limited to like the first day when they go home. Some people are nervous about having some pain, but essentially a lot of the discomfort is handled with muscle relaxants or even anti-inflammatories. So shifting gears just a little bit. So now that you've had the treatment for the cancer, Dr. Sheldon talked about screening. You go into a different mode, which we call surveillance. colorectal cancer, if it's going to recur, will recur most commonly, most commonly within the first 2 years, which is why what you'll see here with the NCCN guidelines, and this is the ASCRS, which is our Society of Colon and Rectal Surgeons. What they have in common here is that the first 2 years, patients will tend to have a little bit more intensive surveillance with labs every, 3, 6 months, 12 months, CT scans once a year, colonoscopy at the first year and 3 years. And then as we get further and further out from the treatment and diagnosis, we're able to start also increasing the length of time. And so after 5 years, if nothing's recurred, anything like that, we essentially consider the cancer cured. And yes, you still need to have your screening, but it's not as intensive. So if I can leave you with just one thing, it's this, what Dr. Sheldon was saying, colonoscopy. It is really not as uncomfortable as this picture is, but it really does save lives. And if we can say anything during this colon cancer awareness month, it's please get your colonoscopy if you're due for it and you haven't, and help your family members get through their fears of it as well. I want to thank everybody for your attention, and that's the end of my presentation, and I'm sure we'll be taking questions.
Thank you. That was really wonderful, and I appreciate your nerdiness. And I want to say thank you to Dr. Sheldon also. Some amazing information. It really covered from beginning to the end of what a patient goes through, and clearly the technology is amazing. So thank you.
I see there's a question here. There's a person asking that they had an appendectomy in 2018 and then they had a colonoscopy. How often are they recommended? Well, hopefully you only need your appendix taken out once. But as for colonoscopies, it honestly depends on, like Dr. Sheldon was saying, risk factors. What did they find at the time of that colonoscopy? Were there polyps? How many polyps? What kinds were they? How large were they? And what family history, et cetera. So there's a lot of criteria that go into it, and that's why it's important to have that dialogue with your whether it's a surgeon doing the colonoscopy or your gastroenterologist or your PCP, to make sure that that's being kept up to date. But generally, depending on the findings, you might, if there are some polyps or they just need to be surveyed, it might be every 3 to 5 years. If the colonoscopy is completely normal and there are no other risk factors and most importantly no symptoms, then we would say usually every 10 years.
There's a new question.
The question is avoiding red meat and processed meats a good way to avoid colon cancer? When looking at things like associated with red meat and processed foods, there haven't been any direct correlations. Like no one has been able to look and draw a straight line between red meat and processed foods all the way to cancer. Having said that, there are associations. So when you look at kind of the preponderance of people who develop a colon cancer, and then you look at like lifestyle, dietary, behavioral type things, there has been a relationship between red meat and processed foods and cancer. But I think that's also kind of common for a lot of different cancers, not just colon cancer. However, it is something that we do talk about. Diets, as Dr. Sheldon had mentioned, that are high in fiber, but also taking a fiber supplement. A lot of patients will say, well, I'm already eating a high fiber diet, but oftentimes taking that fiber supplement on a daily basis gives you a good kind of baseline to work with, so that if you don't get the 35 to 40 grams a day that are recommended, which can actually be harder than you think, at least you're getting a certain baseline to have nice soft bowel movements that, and we know that fiber also helps, with ridding the colon and ridding the body of certain toxins and things like that. So it's not a bad thing to do to take fiber. Also, we may have heard in the news that, especially, I know Dr. Sheldon's a vegetarian. I like my barbecue, but that char and things can be carcinogenic on meat, et cetera. But again, you'll see that in relation with a lot of different cancers. The next question is, if a polyp is found and it is not cancerous, what's the likelihood of finding more polyps within 5 years that would also be of concern? That's a great question. So I know we've referred to polyps as precancerous. I think that's a loaded word. It's very scary for a lot of patients because, even though you're saying pre-cancer, the patient, if it was me, I'm just hearing the word cancer in my mind. I'm going, oh my God. But in reality, it's kind of like having a heart doesn't make you pre-heart attack, or a brain makes you pre-stroke. But these are terms that are used, that we use, that unfortunately are used in the literature, and that we tell our patients. Ultimately, it depends on the size of the polyp, the number of the polyps, and then really, as I had mentioned before, the biology. What kind of cell is it? There are certain, hyperplastic polyps, for instance, which are really just kind of normal lining, essentially. They're just a variant of normal lining. But then you can get into these adenomatous polyps, which have glands and other things. And those are polyps that, and different kinds of stratifications, if left to their own devices long enough, could potentially turn into cancer. So again, I'm not trying to be coy, but it really just does depend on your actual history and what the findings were at the time of that colonoscopy. And what about hemorrhoids? They can cause a little blood during a bowel movement. Should this be checked as well? So certainly, Dr. Sheldon had mentioned this, that oftentimes, common things being common, when you see a little blood in the toilet, and you go, oh, it's probably just my hemorrhoids, and that may be. Having said that, you would expect that if it's a hemorrhoid, that things should resolve, like after the thing that set the hemorrhoid off, which is usually irregular bowel movements, be that really bad diarrhea, really bad constipation, straining, low fiber diet. You would expect that after you've kind of been over that episode, that should go away. If you are seeing that it is a persistent thing, then certainly that needs to be checked. There's nothing wrong with, being better safe than sorry. And again, that would be what we would ask when somebody comes to our office saying, I've been sent here because I think I have hemorrhoids, or I'm coming to you because I think I have hemorrhoids. What we're really starting to look at is, okay, well, first of all, let's look and see, do you really have hemorrhoids? Are there other factors that are playing into it here? I'm sorry, I just got distracted for a second. So, but yeah, so do we see the hemorrhoids? Is it in relation to the bowel movements that you had? What kind of diet you have, etc.? And then we go through family history and other kind of. We go into very specific detail and nuance, and ask you a bunch of strange questions about your bowel movements and habits and things like that.
Frankly, how often do any of us get, so much time with two expert colorectal surgeons? So really, thank you for this fantastic presentation. We have recorded it. It'll be available on our website at baystatehealth.org for future viewing. And as Cindy said, this has been very helpful. And she hopes you get your new cool robotic tool.
As do I. I really hope we do as well, because it's. I think it would be an excellent addition to the arsenal of things that we I just have to say that I am blessed, as Dr. Sheldon said, to work with a great team at Baystate, not just within the colorectal surgery department, and I would let any of my partners operate on me or my family members, but also the multidisciplinary team that we have. We're very collaborative, very smart people, and honestly, we are offering the breadth and depth of things that you would find, at any other, quote unquote, big name institution, even, the cutting edge technologies that we're using for both, chemotherapy and surgery. And I also have to say that, we are always in service to the patients. So there's a lot of times where we have discussions in our multidisciplinary tumor board meetings where, the oncologist might say, for this patient, in this specific case, there is a trial ongoing that we're not a part of, but such and such a place is a part of. We should refer that patient there. And we've done that because ultimately we want what's best for the patient. And there's not an ego about it. It's not about our ego. It's about giving the best care and making sure the patients have the best care. So, I think I've been very lucky to be a part of an institution like Baystate that can offer those things.
Wonderful. Thank you both so much. Have an excellent evening.
You as well. Thank you, everybody.
Thank you.